Cases of COVID-19 are declining worldwide, but with the emergence of coronavirus variants, experts say this could lead to an increase in cases. Hello, I'm Mike Walter sitting in for Anna Naidu, and this is The Heat. The number of global COVID-19 cases has declined for a fourth week in a row. That's according to the World Health Organization. More than 3.1 million new cases were reported around the world last week, the lowest number since the end of October. The WHO considers this encouraging news. Experts from the WHO also ended their trip to China, where they were researching the origins of the virus.
The findings suggest that the laboratory incidence hypothesis is extremely unlikely and to explain the introduction of the virus into the human population, and therefore is not a hypothesis that will implies to suggest future studies into our work to support our future work into the understanding of the origin of the virus.
To discuss the pandemic, let's bring in our panelist here in Washington, D.C. Gavin Macgregor-Skinner is a director at Global Biorisk Advisory Council. Devra Davis is an epidemiologist advising governments and policymakers. She's joining us via Skype from Jackson Hole, Wyoming. Also via Skype from Boston, Yaneer Bar-Yam is the co-founder of the COVID Action Group and president of the New England Complex Systems Institute. And from the other side of the Atlantic via Skype, Chris Smith is a consultant clinical virologist at Cambridge University. Welcome to the program. Chris, why don't we start with you? We've talked about the good news. COVID cases on the decline worldwide. Why do you think that is?
Well, many countries have implemented a return to a much hated lockdown state. And lockdowns, while very, very costly in many levels in terms of people's education, people's economic prospects, countries' economic prospects, they do break the chain of transmission, because at the end of the day, the way this virus transmits is by preying on our humanity, the way we work, the way we live, the way we travel. And if you minimize those interactions between people, you break the chain of transmission, and therefore cases come down. And that's exactly what we're seeing.
So, Gavin, cases coming down. The other good news, vaccinations going up. The CDC saying about close to 1.5 million doses per day administered last week here in the United States. That sounds great, but at this rate, it's still going to take a long time to get herd immunity, right?
Yes, it will, Mike. It's going to take us many more months to get to that magic number, or that percentage we need for herd immunity. And again, we've got a number of restrictions at the moment that are holding us back. People, the resources, getting the vaccines to the vaccine clinics, transportation, and then just the confusion around how to make an appointment to actually get in line, in your place in line to get the actual vaccine.
And there's been this uneven response in different states. A lot of citizens unhappy, governors as well unhappy. They're not getting the vaccines as quickly as they'd like to. Where should the numbers be ideally, and what do you think needs to be done to remedy some of these hiccups?
Mike, that's a really good question. I work in a number of vaccine clinics, and I can tell you everyone who works in those vaccine clinics, in stadiums and convention centres is where I focus most of my attention. We're working really hard, really fast, and putting in long hours. We can't do more vaccinations per day without more people. That's really our limiting factor where we are at the moment, is more people. And then more vaccination sites, like utilising more stadiums and conventions. That's what's really needed. But more importantly, Mike, is making it easier to make the appointment, and making it easier for people to get to these clinics. If they can't, then we've got to go back into the neighbourhoods and start vaccinating at the neighbourhood level.
And Devra, he's talking about people. I know the White House task force talking today about bringing back retired physicians, nurses to help with the administration of these vaccinations. But what more? I mean, I guess you have to think outside the box. What more could be done, do you think?
I'm sorry.
Go ahead,
right
Devra.
now. Yes, thank you. Right now, I think that we're seeing the failures of planning from the last administration. They're glaringly evident every day. And what more needs to be done is we need to target the Black and brown community that have died and been sickened disproportionately with this virus. And that means reaching out more effectively to the local community organizations that already exist, that people respect and rely on. It may be churches, it may be community centers. It's things like that that people in our country have turned to. But remember, we're the United States of America, and traditionally the states have the authority to protect public health. What we have lacked is federal leadership. That's changing. And now with the activation of the Defense Production Act and the production of more of the things we need to get these syringes out there and get the vaccine out there, that's going to be helpful, and more personnel will be helpful. But we've got to go to where people normally go and not make this something extraordinary, like a trip to a football stadium, when you could go around the corner and more easily get this at the local drugstore or supermarket.
And Devra, the numbers, 71% of Americans say they want to be inoculated, but 29%, almost a third of the population, says they don't want any part of this. That also presents some problems moving forward in terms of bringing this under control, doesn't it? And where do you get those numbers to come back up to where people want to go out and get vaccinated?
Well, I think modeling is going to be important. I think Vice President Harris has already shown she wants to provide some leadership there, and we have a special responsibility to the minority community because the history in the United States has been grim with respect to that. There were experiments conducted on blacks without their permission in the 40s and 50s, and the syphilis experiment that was carried out at black medical schools with collaboration from the U.S. government. That's not a deniable fact, and because of that, we have this history of doubt and skepticism, which unfortunately we've earned. So I think we have to recognize what the real barriers are and make efforts to go around them.
And Yaneer, to that point, blacks and people of color die from COVID-19 at a rate nearly 3 times that of whites, and yet when it comes to vaccination, some of these underserved communities, they're missing out on this. What more needs to be done there, do you think?
So first of all, I think Devra said something very important, which is that making it easy in the community. And one thing particular she said I would like to emphasize is pharmacies. Local pharmacies have the ability to provide vaccinations in the community where people already are. Of course, other community locations can be used, but that really helps. But the other thing is that if we want to have the community trust, then it has to be a community that is engaged with this effort. And presenting this as something that's coming from outside the community is not the best way to go. And it's also not the way to empower the communities to stop the transmission in the community. As was mentioned earlier, we're back in a state of lockdowns around the world because of the transmission, and in the United States, like other places, by having community ownership and responsibility for stopping transmission, we can dramatically reduce the transmission. And relying on the vaccines to get us there is not going to get us there in any reasonable amount of time, even if we optimize the delivery of the vaccine.
Yaneer, how much of a concern is the anti-vaxxers, though? Because they did present some problems in Los Angeles at Dodger Stadium when they were trying to get the vaccines into the arms of people. And if 30% of the populace says, well, we don't want any part of this, then the virus still continues to surge through the country, doesn't it?
Yes. I mean, the point is that we are very far away at this point in time from vaccinating, the 70% of the population that is willing to receive it. We're talking about doing 100 million vaccines in 100 days. So that's only 1/3 of the country. So we have a long way to go before we run into that limit. So rather than really being so focused on the challenge at that point, I think what we need to do is to allow the process to take its course. As more and more people get vaccines, more and more people will understand that it's safe, assuming that, of course, that's the information and that's what the indications are. And so rather than being focused on that, I think what we really need to do is to focus on the process of the concerns that we have about the fact that the vaccines are being bypassed by new variants, the fact that we have within a month expecting that the new variants are going to be dominating and accelerating the transmission and increasing the fatality rates and bypassing the vaccine. So we have multiple challenges, and focusing on the issue that people are reluctant to get vaccinated is not the essential thing that we need to focus on right now.
Okay, Chris, let's talk about variants, because as you know, in the UK, this variant cropped up. It seems to move really, really quickly through the population. talk to us about the concerns about it. I mean, you've lived this experience there in the UK. Describe it for us, because here in the United States, we're starting to see more of these cases cropping up.
Well, back in September, we now realize here in the UK, a new variant was detected. It's dubbed B117, or the Kent variant, because Kent is the part of the country down in the southeast where it's first detected. And in fact, what happened is that researchers, we have an amazing organisation called COG UK. They're a consortium who take a proportion of the positive tests conducted across the country, and they use what's left over from doing the PCR test to make the diagnosis, and they read the genetic code of the virus end to end from those positive cases. And this means that they can create effectively a giant radar screen for what the virus is doing in terms of its genetics. And you can do that geographically, because you've got these samples coming in as a representative snapshot of the entire country. And this is a phenomenal opportunity to study how viruses evolve, where they're spreading and what's causing what. And a blip appeared on that radar screen in September, but at the time it was a very tiny blip, but it was a blip nonetheless. But by November, that blip, that genetic change, this variant was accounting for 1 in 4 of the transmissions in some parts of the country. And by about Christmas time, that 1 in 4 had become more than 70% in parts of London, parts of the southeast and the east of England. And that told scientists that whatever this variant was, it was much fitter in terms of its ability to spread and transmit through the population compared to, shall we call it, the classical parent strain of coronavirus we've been contending with before that. And now what we're seeing is across the country, we've got this variant has already spread, it's disseminated quite broadly, and now it's also disclosing variants on that variant. At the moment, we don't have much evidence that it's making people much iller when they catch it, but what it does appear to do is to spread with greater efficiency. The estimates predict that it spreads 50 to 70% better than the parent strain.
So actually there is, sorry, and let me interrupt for a moment, there is evidence that it's 60% more severe, including lethal, already. I don't know whether you saw those studies and reports from the government.
We have limited data on that, actually. Some studies suggest there's not much more lethality. Other studies suggest that it might be about 30% worse for a person. But remember that 80% of people won't have a problem with coronavirus if they catch it, and half of people who catch it don't even know they've caught it. So I don't want to alarm people that we're suddenly talking about something that's 40 to 60% more lethal. Remember, you're talking about 40% more lethal for something that's already got a low likelihood of making you particularly unwell, but at the same time it's a problem because it spreads so voraciously.
Excuse me, the point is the following. If it's spreading more rapidly, then there are many more cases. So even if it's just 40% more cases, then the extent, the number of cases that are going to be hospitalizations and deaths actually goes dramatically up. And in particular,
and that's what I was saying. Yeah, I mean, I don't dispute that. You're going to get more severe cases. That's certainly true.
Has led to the need to close the schools in the UK when they didn't want to, and now it's recognized in multiple countries that in fact one cannot have schools that are open with these new variants, even to maintain the transmission rate at R equals 1. So dramatic changes in implementation of restrictions, in particular across Europe and other places in the world, because of the fact that it's a more rapidly spreading variant, and in particular among children.
Hey, Gavin, let me kind of piggyback off of our discussion about this variant described as the Kent variant. In Denmark, they've done a lot of genomic surveillance tracking this type of virus. One Danish expert says we are in the calm before the storm. These variants will pick up. The number of cases and deaths will actually accelerate. One of the other things they talked about is even during lockdowns, they're seeing this spreading. So what are your concerns here in the U.S.? I mean, you're putting the shots in the arms, but as you said, it's not happening quickly enough. What's the fear moving forward?
The fear right now is that we're not using all the tools that we have in the toolbox. Again, we've heard mention genomic sequencing. There's a lot more genomic sequencing that could be done here in the US if we engaged university laboratories, for example. So we understood. The big point about the variants is about how they have changed in relation to the effectiveness of the vaccine. remember that it doesn't matter what variant you have, it's still SARS-CoV-2 virus, it still causes COVID-19 disease. And I've seen thousands of patients, and I don't like this virus. I don't like what it does to people, regardless of whether 50%, 80%, who cares whether they get sick or not. When people do get infected by this virus, too many suffer. So right now we're very concerned as we see the variants, whether they come from South Africa, the UK or Brazil, or even here in the US, whether they're going to dodge part of the vaccine and they make the vaccine less effective.
And Devra, let's talk about South Africa and Brazil, these different variants. What are some concerns that you see? Because we've mentioned the Kent, but we really haven't touched on the other two that also are getting a lot of press of late.
Deborah, as my colleagues have just indicated, the real challenge is two things: how much more infectious are the variants, and how much more lethal are they? And those are two separate questions, but they are related, because even if they're not more lethal, if more people get the infection, then more of them will sicken, more will be hospitalized, and ultimately more will die. And the fear with the South African variant is that it appears to be both more infectious and more lethal. And as my colleagues have interestingly pointed out with their exchange, we are basically being asked to figure out how to fix a bus that we're driving in right now. We don't have the luxury of waiting 5 years for more data. And that is why, unfortunately, public health has looked a little awkward here, because we're constantly lurching from one to another idea. Take the example of schools. We know that young children benefit enormously from face-to-face interaction, and we have growing concerns about creating electronic zombies with little kids who are attuned to screens and aren't really absorbing and learning through eye-hand contact and visualization and looking and touching and feeling, which is the way young children learn. At the same time, we recognize that there is a danger in some environments for an increase in infectivity. And the schools problem is a huge challenge to public health, because it is not a healthy environment if children can't learn, but it's a very unhealthy environment if their teachers and parents are going to sicken and some of them will die. And that's our challenge right now. So the South African variant does look to be certainly more infectious and potentially more lethal. And the Brazilian one, I really would defer to others here, but I understand that it may have a similar traits. And the problem we have is, unfortunately, it looks like in the UK right now, we have all of the variants working at the same time, and it's really going to be a Darwinian survival of the fittest virus, if you will. And that is why lockdowns, unfortunately, are going to be unavoidable for the foreseeable future. And we're seeing all over the world now lockdown fatigue. People are rebelling against lockdowns. They're tired of it. And we have to do a better job of explaining to people that that is the only guarantee of stopping transmission of these viruses right now.
Devra,
if I can add something.
Go ahead, yes.
There's really growing recognition that the method that was used in Australia and New Zealand, the elimination strategy, is a strategy that we all can use. There recently was an editorial in The Lancet by the chief editor about this, saying that now we realize that this is not only necessary, but also possible. There's really growing recognition that rather than playing with these yo-yo lockdowns where we have to go back and forth into lockdown situation, that if we do the real strong effort, that we can make the lockdowns that are happening now the last lockdown by getting to zero and opening up the way Australia and New Zealand did to normal activities.
But Yaneer, what about the pushback? So many people say, what about the mental health aspect of just being cooped up in your house? And as Devra was pointing out, there's just this fatigue. People are tired of it.
Yeah, but I think we're the ones who are doing it for a whole year. If you look at what's happening in Australia and New Zealand, in Australia, they're having the Australian Open with 10,000 people in the stands. And the reason is that they did it in a targeted way. They went all out and they got rid of it. So they don't have the lockdowns. We're the ones who have the lockdowns. And so the
with
recognition...
a very tiny population. I mean, come on, let's be honest here.
No, sorry.
The whole of Australia you could fit North America inside the Australian continent.
Vietnam has
and there's 22 million people in that country. The population density of Australia is absolutely tiny. It's not a comparison that we can make.
All right, Chris.
There's 500 million people in Europe.
Chris,
350 million.
Chris, hold for just a minute. Let Yaneer finish his point, then I'll get back to you, Chris. Go ahead, Yaneer, finish.
A quarter of the world's population are living normal lives, pre-COVID, or if you like, post-COVID lives, where they don't have to deal with a virus, they're not in lockdowns. And the reason is that the public and their governments decided to get rid of it. And we have Atlantic Canada that has shown that we can do that in the Americas. This is not a cultural problem that's across cultures. There's Western cultures and Eastern cultures. There are lots of different governments and lots of different things that have been done. But what was recognized by the people in those countries is that it was a choice. They put the choices, they compared them on the table, they said, this is the best choice, and they took it. And what's happened in much of the West is that the fact that this was a choice was not recognized. And that's been the limitation, and that's been the failure of the system.
And Chris, I want to get to you, give you a chance to respond, but he does have a point about this kind of yo-yo response, this back and forth. It's better just to do a targeted approach, as Australia did, isn't it? And kind of squeeze the virus shut rather than this back and forth.
Australia managed very well, but the fact is that you cannot compare apples with oranges. Australia is a massive continent with a tiny population. You could fit the whole of the US, you could fit the whole of Europe inside the Australian continent, and there are fewer than 25 million people there. There are 350 million people in the US. Well, let me finish. I'll let you finish. There are 350 million people in the US. There are 500 million in Europe. Those populations are highly connected with a really high population density. It's much harder when you've got that sort of population density and the lifestyles that people have become familiar with and rely on for their livelihoods. It's much harder to disentangle that and to use the sorts of strategies that work for an island nation with a small population. New Zealand, very good example. It's a very different kettle of fish when you have a big continent with lots of connected individuals, high population densities in big population centers. It's much more difficult to control something where 50% of the time there are no symptoms and the thing is untrackable.
Okay,
and that's the problem.
Sure, but we're going to have to kind of leave it there because we got a lot of ground to cover, and I think we're just going to agree that the two of you are going to disagree about this. Gavin, let me ask you this about vaccinations, because everybody sees them as a silver bullet, but the process may be longer than we thought. Let's listen to British Prime Minister Boris Johnson.
I think we're going to have to get used to the idea of vaccinating and then revaccinating in the autumn as we come to face these new variants.
And we'll stick with Johnson. Johnson & Johnson CEO says people may need to get vaccinated against COVID-19 every year due to mutations. Is COVID here to stay, Gavin?
This is a really good question, Mike. And again, we're thinking it may be. And it may be taking that pathway very similar to influenza, the flu, where we have to get a flu vaccination every year. But the challenge we've had right now, Mike, is that lack of education, the lack of awareness for, again, the American population. So when I work in a vaccination clinic, my job is being slowed down because everyone who comes to the vaccination clinic has the same questions that we have to deal with on an individual basis. If we had this like a national education campaign, I think we'd be able to move a bit faster in the vaccination clinics.
Devra, I see you shaking your head. I want to get your thoughts on that, and also how soon before we see Johnson & Johnson, Novavax, some of these others getting emergency use authorization, and what difference will that make in terms of combating this?
Well, it's certainly, the more the merrier is certainly the case. The more vaccines we have out there, the more that are available. But again, I want to come back. We had a fundamental failure of national leadership in the last administration. There absolutely should have been a national campaign for public education. That's what public health is. When we succeed in public health, things do not happen. People do not sicken. They do not die. They do not get the flu. Actually, I want to suggest a silver lining in all of this. With all the mask wearing that has gone on, we are seeing lower rates of influenza deaths right now than we have seen in years past. And I don't think this is just misclassification of COVID for influenza. I think there's a genuine decrement of influenza morbidity and death right now. And that's because more people are wearing masks, and that's been a benefit. But as to the vaccines coming down the pike, it certainly is the case that the Russians and the Chinese have shipped their vaccines out. For example, Serbia is leading the world in vaccination right now because they got vaccines from China, I believe, and Russia as well in January, whereas the other companies have not been able to ship theirs until much more recently. And so this is one where we really cannot discourage the proliferation of different vaccines, because I think that Boris Johnson has it right. I don't think we're going to necessarily need an annual revaccination for COVID SARS-2, but I think we are going to need to see at least every 2 or 3 years a booster, if you will, for the foreseeable future, because this is a wily virus. These spike proteins, they seem to evolve very, very quickly, and we're seeing it as we're trying to solve this puzzle in which we are riding right now.
And Devra's talking about, this morphing. Yaneer, I want to ask you about Peru this weekend. A shipment of Sinopharm vaccines from China arrived. The interim president got his inoculation. They're starting the process there. But we're seeing kind of an uneven response as well worldwide, where some countries may be doing this more effectively than others. And there's always been this concern that the rich countries are going to do really well with the vaccination, some of the poorer countries not so well. What's your sense about that?
So there are a number of challenges, right? Because the new variants are going to create problems. South Africa has stopped using the Pfizer vaccine because they say that it's not effective against their strain, which is already spreading around the world, including has gotten to Europe, in Austria on the border of Germany and Switzerland and Italy. And so we're expecting it obviously to be very common in Europe unless we take action. And really the biggest point is the following. The vaccine is one of the tools that we have. If we take the action to reduce the amount of virus, which, as you said at the beginning, we're seeing that happen over the last 4 weeks. If we dramatically reduce the amount of virus in the world, it not only is better for people in terms of health and better for the economy, because we can then open the economy in areas that don't have it, but we also have fewer opportunities for the virus to mutate. In fact, this virus doesn't mutate as rapidly as other viruses. And the reason why we have so much mutation and so many new variants is that there's just so much virus out there that we're getting these new mutants because of the number of mutations that can happen with that amount of virus.
And Chris, I'm going to give you the last word on this. We've got about 45 seconds. The UK Transport Secretary says the British public should expect strong action when it comes to travel. They're talking about a maximum 10-year jail term for lying about your recent travel history. Is that going to be the future that we're going to see now, where they're really going to lock down these folks who are traveling?
Well, actually, many have opposed that and said they don't think that's likely to be imposed, because 10 years is what you would get for a violent assault with a weapon. And so it seems a little bit disproportionate. So it's a threat, but probably won't be carried through as far as we can tell.
Devra, last word.
Yes, I think that the risk of air travel has been hyped way out of proportion to reality, and we have to look very carefully at the data and not just react emotionally, and let the politicians should not be making policy when it comes to this, but we really do have scientific evidence, and we need to follow it much more carefully. That is not necessarily going to mean banning air travel, but it may mean enforcing penalties for lying about whether you have a COVID test, or it could lead us to COVID passports, which is a whole other ballgame you may want to talk about another time.
Yeah, maybe another show. Devra, thanks so much. Want to thank all our guests. Really robust discussion. That's it for this edition of The Heat. I'm Mike Walter, Washington, D.C. Thanks so much for being with us.